When people meet my son, they don't see the mental illness.
Hey mom, I stopped reading, I'm gonna go.
They don't see the 20 hospitalizations. They don't see that he hallucinates or that he's attempted to kill himself. Because deep down, he's a really good kid.
There you go, mama, there you go.
He really does try to make the right decisions. He strives to be a normal kid, but he has something that holds him back from doing that.
I see things my own way. Sometimes I feel like if it's not my way, then it's no one's way at all.
My son struggles with bipolar disorder. He has ADHD, anxiety, depression. He has psychosis, which sometimes causes my son to be put in the hospital.
I was hearing voices, and all of a sudden I had the urge to cut, so I started cutting it with my arm.
For a while, I thought I hated my son. I thought I resented him, because of everything I've gone through. And you're still having thoughts of killing yourself?
Yeah. Like, they're saying, like, good job. And then some other voice came and was like, do it again. I'm just trying to get my head straight. I was just thinking like thoughts. Like something in my head was just telling me, Daniel, just do it. Get it over with already. You'll feel so much better as a ghost because you won't have to feel these feelings. You can't cut yourself. You can't die because you're already dead, so.
In Daniel's case, I know he's tried to hurt himself several times, and in the majority of those times, he was very upset. Different things going on around the house or around home that really stressed him out, and he couldn't cope with that. He couldn't deal with that, and he didn't know what else to do. And that was his way of trying to deal with it, is he just couldn't really take that any longer.
All right, let's start with the quiz. Which symptom is considered to be a negative symptom in schizophrenia? Delusion, hallucination, disorganized thought process, apathy, or there's no such thing as a negative symptom? How many say delusion? Okay, hallucination? Disorganized thought process? Do you see all up there as an option? Are you having a hallucination of the visual type? Apathy. I see a couple hands. No such thing as a negative symptom? Oh, maybe. Okay. All of the following are symptoms of PTSD except flashbacks, numbing, hypersomnia, hyperarousal. Are flashbacks a symptom? Numbing? No. Hypersomnia? Hyperarousal? Yep. Okay. The treatment of major depressive disorder may include antidepressant medication, cognitive behavioral psychotherapy, transcranial magnetic stimulation, amino acid infusion, electroconvulsive therapy. Antidepressant medicine? That was an easy one, right? CBT? TMS? Amino acid infusion? ECT? Did pretty well on that one. Obsessive compulsive disorder includes all of the following symptoms except recurrent intrusive thoughts, repetitive urges to check, the need to excessively count, aggression toward others, urges to curse in church. You can't have two no's. The following is not an established personality disorder: narcissistic, borderline, depressive, antisocial, schizoid. You're pretty smart. Actually, I'll tell you that for years, the psychoanalysts those are people who completed residencies in psychiatry and then went on to psychoanalytic institutes to learn psychoanalysis. You know, Freud. Free associating, that kind of thing. We can talk more about it another time. But they wrote about this thing called the depressive personality. It's not accepted by the American Psychiatric Association as a true personality type. And in fact, research has shown that the people we used to think had this depressive personality were actually suffering from a mood disorder called Dysthymic Disorder. And you'll see in a couple of minutes what that is. Okay, what do we mean by psychiatric? Pertaining to those parts of the brain responsible for thoughts, mood, behavior, and interpersonal relationships. And when did you first notice this fear of frying? Remember I told you about those parts of the brain that are responsible, right? The prefrontal cortex, orbital frontal cortex, the amygdala, hippocampus, ventral tegmentum, nucleus accumbens. These are the parts of the brain that are involved in addiction, but it turns out they're also involved in all of these other major psychiatric syndromes. What's on a man's mind? You just saw it. You see, it's one of those visual tricks. But of course, Sigmund Freud thought that everything, at one point in his thinking actually, stemmed from sexual urges. Okay, so a patient presents for treatment, and our typical practice is to have them sit in what has lovingly come to be known as the hot seat that is in community right next to me, facing community. I discovered along the way of the evolution of this program that I gathered a lot more information from and about the patient in the community setting than I did from meeting that individual in my own office alone. For many reasons. I'm still working on the explanations for why that probably is, but there are many reasons. The first of which is that I can detect when the individual is not being truthful with me because I see the facial expressions on other members in the community, questioning what was just said. Many times when I think to myself, they don't think he's telling the truth right now. I would have bought it, hook, line, and sinker, in my office. I've learned the tools that have been created in community, being in a group setting, to be able to extract the information I need to understand what's going on with that individual. Now in psychiatry, unlike other areas of medicine, we're doing the examination at the same time as asking questions, gathering history. You go to see your primary care physician, he's asking you questions first, then he does a physical exam. In psychiatry, we do it at the same time. So I'm noticing these features of his brain function as I'm asking questions and he's responding in his characteristic way. We look at the general description, his appearance. Is he well-dressed? Is he malodorous? Is he darting his eyes around the room? Is he cowering? Et cetera, et cetera. Picking up pieces of the puzzle that will create this clinical picture that is consistent with what we think the diagnosis is. looking at his attitude toward me, the examiner. Is he cooperative? Is he defiant? Is he paranoid? Etc. Mood and affect. Mood is something that is subjective, like pain. We can't look at somebody and know what their mood is. We have to ask them, tell me what your mood is. The significance of that is that there might be a discrepancy between what the person reports as his mood versus what we see in the facial expression of the emotional state. That's what affect is. A nice, simple example of that is the person who is laughing while talking about the fact that his best friend just died. Now, that doesn't necessarily mean, so you can't jump to conclusions when you're doing an examination, doesn't necessarily mean that he's a sociopath, that he has no feeling for the fact that his friend just died. It might mean, in fact, that he has a lesion in the brainstem that is disconnecting the mood regulation from those cranial nerves that produce the facial expression. There are such illnesses. We see that, for example, in severe forms of Parkinson's disease, other demyelinating diseases, something called pseudobulbar affect, the neurologic disease that can create that. So we're examining different aspects and not jumping to any conclusions until we put all the pieces of the puzzle together. Speech, we look at the rate, the rhythm, the volume. Perceptual disturbances, we have 5 senses, right? Taste, touch, smell, hearing, seeing. They feed us information about the environment. Well, maybe there's something wrong with the brain systems that are responsible for those particular perceptions. So for example, if you had a tumor in your olfactory tubercle, if you stick your finger in your nose and go straight back a couple inches, you'll hit it right at the base of your brain. If there's a tumor there, it might create a little too much activity. So you're smelling things that are not there. Those are olfactory hallucinations. Maybe seeing things that are not there because something's going on in your visual cortex, occipital cortex. Maybe hearing things, hearing voices when people are not talking. The temporal cortex is hyperstimulated. There are different illnesses that in which these particular hallucinations occur. Thoughts, we look at the process or the organization of thoughts, how a person is expressing himself, answering a question in an organized way that we can follow it clearly, or disorganized, such that the person might be exhibiting things like flight of ideas or derailment, attempting to answer a question, starting to answer it, and suddenly talking about something completely unrelated, like falling off the train tracks, that kind of thing. The content of thought, we're interested in those things in particular that make us act immediately. For example, suicidal thoughts. That person who's saying, I feel suicidal, I have a plan, and I have a gun. We have to get that person into the hospital immediately, right? Homicidal thoughts. Who was it recently? We had someone talking about wanting to kill his family. Any of you remember? What was the first name? The patient's first name? Yeah. Oh, Savion. Yeah. And I said to the therapist, I said, you must contact the family. It's a federal law. The one thing that HIPAA does not apply to. If a patient tells us that he or she has a plan to kill somebody, we are obligated to inform that person. So homicidal thoughts were always the different illnesses, particularly the psychoses, schizophrenia, schizoaffective disorder. They can easily create homicidal thoughts. And finally, we look at whether the person is believing something that is not true, or at least we think is not true. We had admitted a patient once a few years ago who had somewhat of a thought disorder, some poor relatedness, had been using substances, and was telling us about his family and the trauma that he had sustained. And he told us that he had found his grandfather in his freezer, frozen. And that as soon as he found his grandfather in the freezer, he ran from the freezer outside toward his father's pickup truck, where he found his father had shot himself in the head. We thought that this was a little bit much to believe. He had other symptoms consistent with schizophrenia. We thought it was all delusional. So Vanessa, who is quite the sleuth, investigated online. And sure enough, a number of years before, the police had found just that. He was telling the truth. Apparently, his father had killed his grandfather, hid him in the freezer, and then shot himself. We always need to corroborate whether something that seems to be a bit bizarre might be true and not delusional. So, sensorium and cognition, we're looking at whether a person is alert, what his level of consciousness is. Is he lethargic? Is he obtunded? Is he comatose? Orientation to person, place, and time. We've all had the experience of being disoriented to time. Taking a nap late in the day, it's dusk, you wake up. For a second, you don't know if it's late in the afternoon or early morning. And then within seconds, you automatically orient yourself. Well, there are many psychiatric illnesses that create disorientation to the point where that individual cannot orient himself. Memory is very complex function. We talked about working memory, that's one function. There's also short-term memory, long-term memory. We examine whether someone is able to put something into their memory, that's registration, keep it in their memory, consolidation, and then recall it when it's necessary. Very different functions, each of which might be impaired by a different psychiatric or neurologic illness. Concentration. Sometimes memory problems are really concentration problems. See, you can have intact memory function, but if you have difficulty concentrating, you're not going to put something into your memory. If you don't put it in, there's nothing to take out. So it looks like a memory impairment, when in fact it was the concentration problem. We see that very commonly in ADHD. It might look like the person has memory problems. You fix that concentration with a stimulant, for example, and there's no memory problem. Abstract thinking, that capacity to think abstractly in terms of concepts, to appreciate metaphors, similarities, for example, rather than thinking in a concrete way. Sometimes a patient will reveal that he's at that level of concrete thinking. So then when I hear somebody in the community ask him a question that is using a more abstract concept and the patient doesn't respond appropriately, I'll ask the patient to patient or staff member in community to reword the question a little more concretely, and then the patient's able to respond. Fund of information and intelligence level, of course, are important. We look at their impulse control, their judgment, remember, that capacity to identify the likely consequences of their choices. And certainly, having gathered all of this information about them, how reliable are they? Right? Sometimes we'll listen to an hour's worth of history, what's been going on in the person's life, and they're totally unreliable. We had a patient here. Initially, about 4 years ago, he had come in. He had a severe bipolar 1 disorder. A miracle kid, actually. While he was manic, at a hospital out in, I think it was Washington, Oregon, he jumped out the window of the 3rd floor. He landed on the hood of a car, Did not break a single bone. Survived. It's incredible. So he had come to us, was treated, did fairly well, left us, came back about a year ago. Now, the first time he came in, his mother was initially very resistant to our processes, but we pecked away at her. She finally came around and she became a great support for us. And she was wonderful to have at family weekends too, because she was vivacious and she liked to talk a lot, but she got a lot of you engaged very, very quickly. So we really appreciated her support. When he came back the second time, he had gotten manic again. He had stopped taking his medicine, got manic again. Came back, and we asked him about his mother. He said, she died. Died? Oh my God. You know, she wasn't that old. What'd she die of? Some mysterious illness. He said he thought it was cancer. So we treated him this second episode without her involvement, without any contact with her. He left, stopped his medicine again, became manic, was hospitalized. He went to jail. I don't know what he did, but he went to jail. And Mark, one of our outreach coordinators, got a phone call from him. He wanted to come back to treatment. I said, okay. He was manic again. He did something that got him arrested. And then Mark started telling me about the phone conversation that he had with his mother. I said, Mark, he told us that his mother died last November or whatever it was. He said, no, I had a great conversation. She wants to be involved in his treatment. Reliability. Okay, the major psychiatric syndromes: substance-related disorders, psychotic disorders, mood, anxiety, personality disorders. These are the ones that tend to require hospitalization or residential treatment, or at best PHP. Many of the other psychiatric illnesses can easily be treated on an outpatient basis. You know, a relatively simple panic disorder, for example, or social anxiety disorder. Those kinds of things that don't involve creating severe symptoms that create tremendous distress or dysfunction. Now, I say all the time that if the patient suffering these disorders would be honest and compliant, every one of them could be treated as an outpatient. All of these different levels of care are all created because these illnesses create dishonesty and noncompliance. It's all about those two things. Most of the substances create psychiatric symptoms. Now that you know about brain function, that should not be a surprise to you, right? Addiction involves the prefrontal cortex. Let me stop there at the prefrontal cortex. Remember, the prefrontal cortex is responsible for thought process, thought organization, the ability to carry out tasks. Well, if the substance is creating disruption in thought process, well, then that can look like psychosis, right? Create delusions, fixed false beliefs. The substances can affect those parts of the cortex that are responsible for perception. So we have alcoholic hallucinosis, for example, and so on and so on. So we refer to them, I referred to one before, the cannabis-induced psychosis, as substance-induced disorders. With our patients who come in having used substances and are presenting with mood symptoms, anxiety symptoms, psychoses, personality disorders, we have to determine whether it's the substance that's really doing it, because the interventions are different. Yes? That was what left my mind earlier when I wanted to
think with Kevin, it had been for a while, and then his paternal grandmother informed me that they had some bipolar on their side. But I kept seeing something that wasn't quite right, and I'm thinking that these symptoms were brought on by cannabis. And then he started saying, about the voices, so I'm thinking, okay, he got some bad cannabis. It became really aggressive. So I'm just wondering if he had not started smoking, would it have eventually come out later in his adult years?
That's exactly the point I wanted to make. Thank you so much. So, in that person who has not been psychotic, starts smoking cannabis, and then becomes psychotic, now we're thinking that that person really has the underlying schizophrenia, most likely. The studies are starting to show that, yes, even if he didn't use cannabis, he would have become psychotic, but probably later in life. And by later, I mean instead of late teens, maybe mid to late 20s. Yeah. Kind of speeds up the process. Yep. Good. Thank you. So the major psychotic disorders that we see are the schizophrenia, schizoaffective disorder, and delusional disorder. In schizophrenia, we see a combination of symptoms including delusions, hallucinations, disorganized speech, grossly disorganized or catatonic behavior, negative symptoms, affective flattening, alogia, or avolition. Okay, affective flattening. remember I talked about the emotions expressed through facial expression. So you can see sometimes in individuals that their facial expression is just flat. You can't read their emotion at all. That's what they mean by affective flattening. That's considered a negative symptom. Let me organize this for you. So in schizophrenia, there are 4 domains of symptoms. The positive symptoms are hallucinations, delusions, disorganized thoughts. The negative symptoms are the flattened affect, the social withdrawal, the decreased desire to do anything, anhedonia, which is the absence of pleasure brought about by doing enjoyable activities. And you see impoverished speech, which means there's just not much spontaneous production of speech. The person can essentially just kind of sit on the sofa staring out into space for hours at a time. There's no drive to accomplish task. Those are the negative symptoms. The cognitive symptoms I showed you with the cognitive testing before. You see it across the board. Verbal memory, visual memory, executive function, etc. And the mood symptoms, which tend to be depressive symptoms. It can look like having schizophrenia and depression at the same time, but now we know that the depressive symptoms are actually caused by the schizophrenia. It's not having 2 different illnesses. Of those 4 different domains of symptoms, the one domain that has been shown to affect level of functioning, how to get along in life, the most are the cognitive symptoms. The positive symptoms are very responsive to medicines, the antipsychotic medicines. The negative symptoms, not so much. The cognitive symptoms, not at all. And the mood symptoms are very responsive to medicine as well, particularly antidepressants. The cognitive symptoms, remember, I told you, respond to cognitive rehabilitation, though. And that's why we engage our patients with schizophrenia with daily cognitive exercises. There are now probably about 30 or 40 antipsychotic medicines. The first one was developed in 1950. The generic is chlorpromazine, the brand is Thorazine. You've heard of it. From 1950 to 1989, I think, there were developed about 20, 25 antipsychotics. The side effects to each vary. The effectiveness does not. They're all equally effective. Until finally, around, I think it was 1989, clozapine was developed. And over the years since then, shown to be the most effective antipsychotic. Even more effective than the 10 or so developed since then. Clozapine carries a risk. It can decrease white blood cells to a dangerous level. White blood cells are the ones we use to fight infection. However, the likelihood of it happening is about 0.8%. So less than 1% of people who take clozapine develop this called agranulocytosis, decrease in white blood cells. If it happens, we have to stop the medicine. We have about 15 patients right now on clozapine. It requires that they have a blood test done every week to look at their complete blood count. And in fact, we have to give the result to the pharmacy in order for the pharmacy to dispense the medicine. If they don't get that result, they will not dispense that medicine. There's a clozapine registry in this country where we have to register every single patient we start on clozapine. So, for example, once they're registered and they have the weekly results of the blood cell count, if something should go wrong and we have to stop the clozapine, if the patient now finds another doctor and says, I've never taken clozapine, we know that they have. So we don't put them at risk of that developing that condition again. After 6 months, it can drop to every other week. And then after a year, it's once a month. It can be very, very effective. You remember the patient Florida sent off to the state hospital, and now she's doing beautifully at their master's program. It can be miraculous, actually, for some. Unfortunately, for others, they may get a partial response, but not a full response. Yes? You read my mind. The clozapine has been the only antipsychotic to have been shown to markedly decrease negative symptoms of schizophrenia, unlike all the other antipsychotics. And so we often see that, and the individual who is kind of hiding up against the wall with the flat affect and the decreased social interaction is now very active and takes initiative and speaks in complete sentences without being prompted. You can really see significant change at times. Right. ADHD. This person suffers from symptoms of inattention, hyperactivity, and impulsivity. On the left, you see the scan showing no ADHD. In other words, the cortex is fully active. On the right, you see a marked decrease in activity. That's what the pathology is in ADHD. Now, the brainstem is what's responsible for producing the energy that drives activity, the brainstem. The prefrontal cortex regulates that brainstem, kind of keeps the brakes on it, releases the brakes to allow more activity, puts on the brakes to decrease the activity. Finely tuned. The healthy prefrontal cortex puts the brakes on. But what if the prefrontal cortex isn't working fully? It's not going to be able to fine tune that. You're going to see a lot more activity. That's the hyperactivity. How about if we stimulate the prefrontal cortex, get it to work fully? Now it can nicely put the brakes on the brainstem. It decreases the hyperactivity. That's why stimulants work in ADHD. Captures it beautifully. In fact, I think the next video does too. Okay, which kid is hyperactive? mood disorders include major depressive disorder, the dysthymic disorder, remember I told you it used to be the depressive personality, and the bipolar disorders. Bipolar 1 and bipolar 2. We'll talk about mania in a second. But I just want you to appreciate a bit of a spectrum. So if you see normal mood in the center, this person with dysthymia tends to be mostly depressed most of the time. Not terribly depressed, but enough just to make life kind of miserable. If it's a little more severe, then we see a mild depression, a moderate depression, a severe depression. If it's more severe than that, the depression itself can now disrupt the thought process in such a way to create psychosis, delusions. It can interfere with those parts of the cortex that are perceiving the environment and therefore cause hallucinations. A psychotic depression, that's the severest form. On the other end, we see a slight elevation in mood, elation, it's also called hyperthymia. We all want to be in that mood state at all times. We would love it. Hypomania is a little more intense than that. People in hypomania do not want treatment. They don't want to change that mood state. It is such a great feeling. However, it is unstable. It never lasts. It will either drop all the way back into severe depression, or it will go into mania. People with mania that goes untreated will become psychotic as well. Delusions and hallucinations. It even goes beyond that. This doesn't show that if that mania with psychosis is not treated, it turns into what's called a manic delirium. That's the person who, in addition to being manic and psychotic, is also disoriented. The brain begins to shut down. We talk about brain failure the way we talk about heart failure. That person dies. It's very rare to see that these days because this person comes to everybody's attention. Hypomania. And he's refusing treatment most of the time, so he's destined to go into mania, but he's followed very closely. And as soon as he becomes manic, we hospitalize him. So we prevent this and we prevent the delirium. In major depression, the symptoms include depressed mood, of course, markedly diminished interest or pleasure. I just said of course, but I caught myself because, in fact, you can suffer this syndrome of major depression experiencing all of the symptoms except for depressed mood. So what we see in that is that some people, instead of experiencing depressed mood, experience the second symptom, which is markedly diminished interest or pleasure. That's the anhedonia. So it's either depressed mood or anhedonia. And then some of the other symptoms. Changes in weight, changes in sleep, psychomotor agitation, restlessness, can't sit still, fatigue or loss of energy, feelings of worthlessness or guilt, diminished ability to think. And that's really what the term depression means. It's a slowing down of brain function. More so than the other way we use depression, which is sadness. Right? That's not what that means, major depression. It's a major slowing down of brain function, except for that tiny area in the subgenual anterior cingulate that I taught you about. Too active, right? Look at this person without depression. Yellow signifies normal activity. The person with depression. So all of this is slowed down markedly, affecting all of those different circuits. Just showed you that. TMS. So effective treatment for major depression includes antidepressants and or psychotherapy. So for mild to moderate forms of major depressive disorder, cognitive behavioral psychotherapy has been shown to be equally effective to medicine. You need a motivated patient, though, who's willing to engage in that type of talk therapy. There are other types of psychotherapies that have been found to be effective as well. The combination of psychotherapy and medicine is most effective. Sometimes patients don't respond to those antidepressant interventions, and so that's where TMS may play a role. The person undergoing TMS sits in the chair 5 days a week for about 37 minutes for each treatment. Initially, it's a little irritating, the sensation, and that is it's like a rapid woodpecker on your scalp. You hear that for, excuse me, just a few seconds, and it stops. There's a delay, and then a few more seconds, and that goes on for 37 minutes. So we try to distract the patient by being able to watch movies on the flat screen TV right in front of them. Aside from that, occasional headache, but if a patient develops a headache, then certainly Tylenol usually takes it away. And then we have the patient take the Tylenol before the treatment, and usually prevents it from happening. So they do that 5 days a week for 4 to 6 weeks to get them into remission, and then often given an antidepressant to try to prevent a recurrence. Because the risk of recurrence, once somebody develops the first episode of major depression, it can come back a second time in about 50% of the cases.
What do you think about the blood test to try to test your genetics to see what antidepressant would be most effective for you?
Carol, that's a great question. It's still, in my opinion, it's still in its infancy in terms of its clinical usefulness. So, for example, I'll tell you that when we take most medicines, not all, but those medicines that are metabolized by the liver, we swallow the medicine, goes into our stomach, then the small intestine, and where it gets absorbed, across the wall, into the bloodstream, brought to the liver. The liver recognizes it as something that's foreign and tries to get rid of it. So we call this metabolism. There are certain proteins, they're called enzymes, that each recognize a foreign substance and begin to break it down. Whatever makes it through the liver that hasn't been broken down now goes through the bloodstream into the brain and does its thing. So we can tell you the approximate amount of medicine that actually will be chewed up by the liver versus the amount that actually makes it to the brain. Ideally, we don't want any to be chewed up by the liver. But we take into account how much is chewed up in order to determine the dose we give you. I'm giving you really sophisticated psychopharmacology here. Now, your enzyme that will chew up Prozac, for example, will do so either faster or slower or at the same rate as my enzyme. It's different in every one of us. Those enzymes, like all proteins, are determined by genes. So what these tests do are they look at those genes to see which ones you have for that enzyme. And the results will read out rapid metabolizer, slow metabolizer, intermediate metabolizer. If you're a rapid metabolizer, that means you're going to chew up most of it. So the little that gets to your brain is less likely to cause side effects. If you're a slow metabolizer, much more of it is going to get to your brain. You're more likely to suffer side effects. So that's what those tests show us so far. I'm thinking, okay, I want to try this medicine. So let me check your genes. I can predict whether or not you're likely to have side effects to it. But it's only a risk of side effects. It doesn't determine 100% that you will suffer the side effect. In my practice, what we see is that I start gentle with most medicines anyway. I get a sense from what you tell me in terms of your tolerance, how quickly I can increase the dose. Some psychiatrists report that they find that testing helpful in determining what medicine they should prescribe. I was doing it for a while, examining the results on every single patient, I never found it helpful. It never was better than what I just found clinically by being gentle and slowly increasing the dose. Yeah. But I think it has a lot of potential. I think it can tell us a lot more and point a little more closely to what medicines we should consider. So related to that is, okay, we have antidepressants. We have probably about 30, maybe even 40 antidepressants to choose from. You present to us with depression, I have to choose one of those antidepressants. Which one am I going to choose? It's not totally arbitrary, because we often take advantage of side effects. You know that some medicines have, as the side effect, the tendency to make you sleepy, right? Benadryl. That's not why you should take it, by the way. But if you're having an allergic reaction, you've got to take Benadryl, and if you do, you feel sleepy. So you take advantage of that with an antidepressant. If you're experiencing in your depression, look, if I look back at the criteria, some people with depression may have insomnia, others may have hypersomnia, needing to sleep too much. If you're experiencing insomnia as part of your depression, then I'm going to choose one of the antidepressants that has as a side effect sedation. And I'm going to have you take that at bedtime. So I'm going to kill two birds with one stone. Depression and your insomnia, you see? But on the other hand, if you have hypersomnia, you just want to sleep 20 hours a day, I'm not going to give you that medicine. That makes it worse. So we take advantage, and there are multiple examples of taking advantage of the particular side effect to work in our favor to treat your depression. Oh wait, I'm going backwards. Sorry. I love those kids. We talked about all this. The Dysthymic Disorders, sort of a milder version of major depressive disorder, but tend to last for longer periods of time. You see similar symptoms. It wasn't until the mid to late 80s that we discovered that antidepressants were effective for this disorder. It was, prior to that, it was treated exclusively with psychotherapy, and most of the time not effectively. But medicine can be very helpful. In bipolar I disorder, it means that there's been at least one manic episode. A manic episode is one in which people experience a number of symptoms at the same time, including inflated self-esteem or grandiosity, decreased need for sleep. That's not trouble sleeping. They don't need so much sleep. They can get away with 3 or 4 hours and feel great. They're on top of the world. They want to do everything. More talkative than usual, a pressure to keep talking. You cannot get a word in edgewise when they are in their full manic state. Flight. Nafi, it just occurred to me why you're shaking your head. Flight of ideas or subjective experience of racing thoughts, distractibility, increasing goal-directed activity. They're just wanting to do a lot, come up with a lot of ideas. They start a lot of projects, don't finish anything. It's not a very productive state. Excessive involvement in pleasurable activities. They take a lot of risks, get themselves into trouble, and this is what gets them arrested. We had a manic female adolescent. She's doing beautifully now. She's an outpatient. But she presented in full-blown mania. The final step, her parents were recognizing that something wasn't right. Couldn't quite put their finger on it until they had to call the police for some, yeah. She had stripped naked and ran out into the neighborhood. So they thought something was wrong. They called the police because they couldn't get her to come back into the house. A policewoman actually approached her, and she walked up to the police and promptly hugged her, telling her how much she loved her. Pleasurable, risky activity. She was promptly put in handcuffs and taken to the hospital. So, you see the difference between the cortical activity in the depressed state versus the manic state. Oh, let me go back to that a second. Bipolar 1 as opposed to bipolar 2. if you decrease the severity of all of these symptoms, that's what bipolar 2 is. Generally, judgment is fairly preserved. It's not so impaired as it is in the manic state. And that person who with hypomania, bipolar 2, likes that state. But as I said, it either goes into, the hypomanic state may go into mania or it may drop into depression. If it's a true bipolar disorder, it does not go into mania. It'll drop into depression. Treatments are pretty much similar. Mood stabilizers, such as lithium, Depakote, Tegretol, and antipsychotics. And in fact, we often use some of the antipsychotic medicines as mood stabilizers. No. Once you've declared yourself as having bipolar 1 disorder, it'll never be bipolar 2. It's bipolar 1 until the day you die.
So to that point, if you happen to find the right cocktails of medication, is it expected that the patient stays on that for the remainder of their days?
Until we find a cure for bipolar 1 disorder. Yep. That's all we know. That often we can simplify the cocktail. So for example, the studies show that the combination of medicines is more effective than individual medicines. So typically, what we do is an individual comes in mania, and we put them on lithium and Depakote and an antipsychotic, maybe Zyprexa, for example, until we get that mania snuffed out. Mania is dangerous. That person with mania can hurt himself, hurt other people, get himself into trouble. You got to get it snuffed out as quickly as possible, whatever it takes. So the combination of those three medicines is often very effective. And then as the patient is recovering and doing well, probably no need to continue the antipsychotic. The mood stabilizers are where the action is. And then, although the combination has been found to be most effective for acute mania, it's not necessarily so that the patient will require the combination for maintenance. In maintenance, you're preventing the next manic episode. And often the patient may be able to get away with just lithium, for example, forever. When I was a resident in psychiatry, I did a study in the geriatric division at New York Hospital, looking at the effects of lithium on kidneys in the geriatric population. Lithium can affect kidney function, and so it's important to monitor it over time. So every now and then we do a blood test to look at kidney function. Well, because it was a geriatric population, I got to see all of these patients who had been on lithium for 40 years. Absolutely phenomenal. Hospitalized once, and then remained on lithium for 40 years. Never hospitalized again. That's the value.
So tying together the 12 steps you talked about before and the cocktail, do you guys keep I know Mike Fox is now doing an alumni thing, but do you guys keep studies on who successfully has gone through and completed the program, and over the course of time, if they've maintained their medication and stayed healthy versus the people who have not?
Not yet. We hope to do that kind of stuff going forward. We've been collecting data since day one, and certainly, James had done a lot of data collection when he was alumni director, contacting people who had been with us in early 2011, for example, and following up on things like relapse rates, or relapse into substance use, relapse into mania, relapse into depression, that kind of thing. What treatments they continued. So we've been collecting it, but we haven't been, they use the verb mining it in order to, draw conclusions. It will be done one day. Not yet, though.
It just seems a challenge keeping them on the program.
Yeah, and in fact, the typical course in bipolar disorder is that the individual stops the medicine. I told you about the guy earlier who jumped out of the third floor window. Kept stopping his medicine. But to be fair, well, he actually helped teach us in 2012 that we needed to institute transitional living. We didn't have it before then. You know, how do we get these patients to stay with us long enough and therefore stay on the medicine long enough to develop the healthy enough state to recognize the need to remain on the medicine? You know, I came from a psychiatric field that just expects the patient to stop the medicine. Like there's nothing you can do about it. They're going to stop. Accept that. It's a fact. So it occurred to me in 2012, no, it doesn't have to be that way. I think if we get the brain healthy enough, the patient recognizes, I don't ever want to stop my medicine. I like the way I feel. Healthy. So they understand that. Yes. 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 And so that's why we created this extended program with the different levels, gradually testing the waters as to, you know, is the patient likely to stop his medicine or not, kind of thing. And how long do we have to actually monitor things so closely before we can get that brain healthy enough? That helped contribute to what the program is today. The little bit of follow-up we've done so far is that patients stay well. Still taking their medicine, still doing well. No rehospitalizations. Yeah.
Where do psychotic features fit in with the bipolar diagnosis?
As these symptoms get more severe, then they will produce the psychotic process. The psychotic process is not necessary for the diagnosis of bipolar I disorder. That's why it's not here. These are the criteria that are necessary. You know, if you only have an inflated self-esteem or you're very grandiose, that does not give you the diagnosis of bipolar I disorder. You know? You have to have most of these symptoms. So you're creating a syndrome that we call bipolar I disorder. Within that, you may go on to develop psychosis or not, but it's not required. Yep.
Can you confuse also with these bipolar 1 and 2 or whatever? If they have to have a mood stabilizer and they're depressed, that's what I don't get. So, could you explain that?
Think of the mood spectrum, our normal mood. Now look, are you super happy 24 hours a day? Right. None of us is. Because it's a mood range that's considered normal. Just like body temperature, right? There's a lower level, a higher level that we consider to be normal range. Anything above that is pathologic. It's abnormal. It means a disease is occurring, right? Our temperature goes above 100.6, a disease is occurring. Goes below 96, a disease is occurring. The idea of a range of functioning applies to every aspect of our body. Every organ system, everything, including mood regulation. Now, the mood regulators, lithium, Depakote, Tegretol, they maintain that mood regulation within these boundaries. Okay. Now, someone begins to drop below that and develop depression, we need to bring that mood back up into the normal range. That mood regulator, mood stabilizer, will prevent, as we try to bring it back up, that medicine will prevent it from going too high. So we have that in place when we throw in our antidepressant, for example. So the antidepressant will bring it up. Without the mood stabilizer, the antidepressant would continue to push it up into mania.